Good morning and welcome to the webinar. Today's topic is getting dementia care right. Thank you for joining us today. These complimentary webinars are brought to you through a collaboration of sponsorship with O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, as well as Alzheimer's Orange County. My name is Lauren Weiss. I am the Educational Services Manager here at Alzheimer's Orange County, and I will be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial for anyone who cares for and works with older adults. We hope you find today's presentation informative and useful. Today, our presenter is going to be Ann Ellett. Before I introduce our presenter, I'll review what you need to know if you are interested in earning continuing education credit for today's webinar. So next slide, Ann. Next slide. Perfect. CE credit is available for RCFE administrators, licensed RNs and LVNs, and for LMFT, LCSW, LEP, and LPCC professionals through CAMP and the BBS. You must be online for the full 60 minutes. You must have access to both audio and visual on your computer. If you want CE credit, do not share your link to join with others. This is your unique record of attendance. If you share your link or use another attendee's link, you will not receive CE credit. Please answer the poll questions immediately. This is a proof of your active attendance. And if you have problem accessing or answering the poll questions, please type into the chat box to let us know that you're having trouble. And you can also type your response into the chat box as well to let us know you're actively attending. If we don't receive any response from you regarding the poll questions, you will not qualify for CE credit. Please complete the survey immediately as you exit the webinar. You will only receive a survey link by email if you do not complete the survey when exiting the webinar. The email with the survey link is sent out 24 hours after the end of the webinar, and this link is unique to you and your attendance, so please do not share it with others. And a certificate of completion will be issued to you by email within 10 days, as long as all the other CE requirements are also met. And just a couple basics for everyone. Your mic and video are automatically disabled and will remain so throughout the presentation. But you will have the opportunity to ask the presenter questions about the presentation by typing your questions into the chat box in the taskbar. We will save your questions and answer them at the conclusion of the webinar. If the Q&A session runs long, you are welcome to stay for that. But if you're requesting CE credit, you are only required to stay for 60 minutes. We will not be responding to raised hands unless we ask you to raise your hand for a specific reason. And again, remember to complete the survey immediately as you exit the webinar. So with all that said, I would like to introduce our speaker today, Ann Ellett. Ann Ellett is a certified nurse practitioner and gerontological nurse, a dementia specialist, educator, author, and speaker who continues to learn from persons living with dementia. For over 20 years, Ann has advocated for innovative and dignified support for people living with dementia. Her book, Getting Dementia Care Right, was published by Health Professionals Press in 2023. As founder and CEO of Memory Care Support, Ann specializes in assisting long-term care and memory care operators across the country to develop best practices for innovative environments in dementia care. She is the author of The Best Life Approach for the Greenhouse Project for supporting persons living with dementia. Ann received a Bachelor of Arts in Social Sciences from the University of California, Irvine, and Bachelor and Master's of Science degrees in nursing from California State University, Long Beach. And she is a certified master gardener. Ann lives in California, and when not working, she is gardening or traveling with her husband. So now I will hand it off to our presenter, Ann.
Oh, thank you so much, Lauren, and thank all of you for spending your time here today with us. So yes, as Lauren said, I'm a nurse practitioner. I've specialized in dementia really for a few decades. And in fact, my very first paid job at the age of 16, I started working in the nursing home down the street after school. And the memories of that really pretty dismal place have stayed with me for all this long time and helped motivate me to want to make things better for people who are living with dementia. Any of you that have heard me speak before have probably heard me say that providing good dementia care is complex. I see new memory and care places kind of popping up here and there, and there's a lot of thought and a lot of special consideration that needs to go into providing good care. It's much more than having a beautiful building. Although I'm grateful for the more beautiful buildings that we're building these days, some of them are really quite lovely. But some of the things that I see that are slow to change, and there's often obstacles to providing innovations in these areas, do we ask ourselves why so many of the memory care residential places, the memory care unit, as they like to talk about it, is a locked place down at the end of a hallway? Um, why do we need to confine and lock people up? Who in our culture do we confine and lock up? And would this be okay? Would this be what I would want? Would this be what you would want? So I ask people to think about that question. The other thing that I see as I work in different assisted livings and nursing homes around the country is often policies and procedures. There's really been very little change to them. I see a template of the same policies and procedures used over and over and over again from one place to the next. Not much new, not much innovation. Also, the levels of staffing and budgets for training. Sometimes there's not been much change in those areas. So I'm challenging those of us that are professionals to ask ourselves these questions. These aren't easy things to change, but at least let's start by asking some questions. I know that there are people listening on today's presentation who aren't working professionally in the residential care communities. You yourselves perhaps are living with dementia, or there's family members on the presentation. And so this is part of perhaps helping you know what good care looks like and questions that you can ask to get yourself information to know about good care. A couple of years ago, I was asked by a large medical center in the state of Iowa if I would do a survey of people who lived in their community who had been diagnosed with dementia and were living at home. So what did they envision for their future? What would they want if they were to move into a residential care community? And these are some of the most common responses I got. And these were wonderful conversations. It was, they were all done on Zoom, so I wasn't able to personally sit with them, but they were very dear conversations. And you heard people really thinking about how do they explain what they hope they want as they move forward in their journey. And these are some of the most common things. And these are, I believe that these are probably the types of things that any one of us would hope for if we were living with dementia and we're thinking about our futures. We want to be able to go outside every day, even if it's cold. And the people in Iowa, they have blizzards there. It gets really cold in the winter. But they said, right now, I might just go to my mailbox, or I might just take my dog out on my patio for a few minutes if it's in the middle of winter, but I go outside, and that ability to access the outside seemed very important. They wanted to be able to keep their own schedule. And I have to tell you, that is one of the really nice things about being older is I get to kind of make my own schedule. And some days I start early and some days I don't, or some days I eat lunch and some days I don't really feel like it. So I get to decide how and where I spend my time. Privacy, it's something that, of course, we have in our own homes. People talked about, would they lose that if they moved into a residential care community? Pets are such an important relationship for older people. Many of the people I spoke with had very beloved dogs and cats, and they didn't want to have to give those up. They wanted to continue to have those relationships. They wanted to be able to walk into a kitchen and fix themselves whatever it is, or open a little bag of chips or have a cookie. They wanted to be able to have their own snacks when they were hungry. The idea of being confined was really scary to a lot of these people. They had visited local memory care places, many of which had the locked unit. And these people I spoke with said, why do I need to be confined? Who am I a threat to? Why do I need to be locked up? So you could go on down the list here. Certainly being able to work in my garden, that would be one of my special wishes if I was living with dementia. But what are we really talking about here? We're really talking about having a normal life. So let's stop and take this poll question, and we'll continue in just a few minutes.
So we have our poll question for you. Individuals living with dementia can no longer express their wishes. Is this true or false? So again, this is, please make sure that you answer the question. And if you're not able to, please put your answer in the chat box. Again, individuals living with dementia can no longer express their wishes. We'll give it a couple more seconds. Okay, gonna end the poll. And it looks like most of us got that answer correct. I'll hand it back over to you, Anne.
Thank you. Um, okay, there we go. This is one of my favorite photos. This is Emma, and she was a lady who lived in a nursing home in Arkansas. I was doing some work down there, and Emma had lived there, I don't know exactly how long, but a few years. And she was living with dementia. Staff really considered her almost, I wouldn't say unresponsive, but she was, they considered her nonverbal, and she didn't really engage in things. And so this photo of her, a nurse, had had a new baby and was coming back from maternity leave, and she brought in her new infant to show her coworkers. And she sat on the couch where Emma was sitting and was showing her coworkers, and Emma reached over for the baby. So the nurse put the baby in Emma's arms, and we were all just flabbergasted. Emma held the baby so lovingly and began to gently rock it and sang it a lullaby. And we were completely, I have to say, blown away, because none of us realized that Emma had that capacity, had those skills within her. But what triggered this? It was exposure to a very meaningful experience, something that was meaningful to Emma. And she had a completely loving and dignified and appropriate response to holding this baby. It was so beautiful. So, what would we want? And in talking with people who are living with dementia, they'll say, I want to be known as an individual. And that's so often as professionals, we kind of paint people living with dementia with a broad brush and go, we use the pronoun they, and oh, well, they don't need to do that, or they wouldn't be able to do that, or they can go outside later, as if everyone has the same desires and the same internal schedule for that. So we really want to be known as individuals. We do not want to be defined by our diagnosis and say dementia is the first thing that people think of, instead of perhaps thinking about what's unique. What's unique to Emma that we could offer her that would engage her and be meaningful to her. And we don't want to be locked up. Think about, as an adult, when, if ever, were you confined? Probably never, I hope. So why would we not expect people to perhaps become anxious or perhaps become agitated if they were locked up or confined. It's not a natural, normal environment for adults. When I work with care teams, we work to say, well, what are our goals of care? And when I discuss things with them, they usually say, well, we want to be sure they're safe. We want to be sure that the residents don't get sick. We want to be sure that they don't fall. And all of those things are very valuable and very worthwhile. But if we think of it as a broader goal of care, we really are wanting to support them to live well with dementia. So I'm saying to live well, we want them to have some meaning in their lives. So these are some of the points that we're going to talk a little bit more about in this presentation. And starting with cure versus culture. Can we offer anyone living with dementia today a cure? No, unfortunately, we can't. We're getting better at prevention. We're finding more and more things that might lead to the development of dementia. And so we're getting better at perhaps preventing it. But can we really say we are on the cusp of a cure? No, we're not. My belief is it'll be a long time if that happens. So really what's important is the culture that we're putting around these people. We can't cure them, so how can we surround them with a culture that supports them? The other thing I ask us all to think of is, what are our misperceptions of people living with dementia? Again, are we defining them by their diagnosis instead of by their retained abilities and talents? Do we just hear the word dementia and say, well, she's probably not able to do that, or she probably wouldn't want to get engaged with that? Are we defining for them what is meaningful? Do we focus on inabilities? One of my favorite things when I go to a new place to work, I ask the staff to walk around and introduce me to the residents. And that's very meaningful because sometimes I hear things, they will come upon a gentleman sitting in a chair and they'll go, well, this was John. He used to be an engineer. Now he doesn't really do much. And then they'll go on to the next person. And this was Mary. She was a school teacher. She can't really read anymore. She doesn't talk much. So what I'm getting from the staff is that they are focusing on these people's losses and inabilities rather than any retained talents and skills. Instead of bringing me to John, who do I immediately need to know that he used to be an engineer and he can't do much these days? What if they said, well, this is John, and boy, when we have music on, he keeps rhythm and he loves to sing with the group. Could they identify something that John is talented and successful with today and focus on his current abilities and talents? Instead of saying that Mary used to be a school teacher and can't read anymore, could I be introduced to Mary as, Mary has the best smile here. And when someone comes and sits with her, she loves to hold their hand and she will tell you about her travels to Italy that she and her husband did. Tell me about something that Mary can do today and is successful at. Do we perceive their actions as behaviors that need to be managed? And we're going to talk more about that. Again, I mentioned that if any of us were confined in a locked area, wouldn't we be pounding on the door, pacing back and forth, going up to people, saying, I want to leave? Wouldn't we be anxious or agitated? That would really be a pretty normal adult action. That's not a behavior. That's an appropriate reaction to what's going on in their environment. And then we're going to talk about measuring the meaningful today. So we talk about quality of life. All right, well, I mentioned cure versus culture. Unfortunately, we're not successful in the cure department. So we really have to create a culture around residents that will support them. And how do we do that? Are we supporting the residents to be the best that they can be, or are we just focusing on what I like to call surplus safety? We're so worried that someone's going to walk out the front door, we're going to lock everyone down, or we're so worried that someone's going to fall, we keep encouraging them to, oh, sit there in the chair, you sit down, when they're trying to get up. They have that desire to walk and explore their environment. So how can we move the culture forward to support people to be the best they can be? Okay, next poll question.
Okay, poll question number 2. You cannot change the culture of your workplace. True or false? Again, go ahead and answer this question quickly so we can make sure that you're actively listening. You cannot change the culture of your workplace. True or false? We'll give it a couple more seconds, give everybody the opportunity to answer. Okay, one last time. You cannot change the culture of your workplace. Okay, we'll go ahead. Everybody's had a chance to answer. Again, great job, everybody. I'll hand it back over to you, Anne.
Thank you. So again, I talk about our misperceptions regarding dementia. I have a couple friends whose husbands have been diagnosed recently with dementia, different types of dementia. And my friends have talked to me about how they were reticent to share that their husbands had this diagnosis attached to them because they thought that they would be perceived differently. They would be, again, defined by their diagnosis. One of my friends, she said, Ralph, he still helps me in the house and we're very active and we still travel together. But if I tell people he has dementia, people are going to start looking for the things that he can't do as well, instead of focusing on Ralph is still Ralph. So what are our perceptions? Again, do we use a broad brush and talk about them as if they're all the same? Do we focus on their inabilities? Safe and clean is certainly important. I'm a great supporter of everyone for their dignity having safety and being good hygiene, but that's not enough to create a meaningful life. And if you are a professional working in a memory care location, I ask you to ask yourself the question, why do we segregate and confine the residents with that diagnosis? Is that really necessary? Why are we doing that? Misperceptions do matter. The Mather Institute did a very extensive research on staff who work with older adults. And those that have positive attitudes performed in ways that better supported resident independence and autonomy. And negative attitudes led to over control and limiting the opportunities for growth and new experiences. It's a very interesting study, but it showed that there were differences on how staff approached and the choices that they offered people, depending on how they perceived that older adult. So really, I think any of us, if we were to be diagnosed with dementia, what we're hoping for is to have a normal life, not to be immediately seen as unable, but be supported supported to still have experiences, supported to be as independent as possible. And how lovely if you have a relationship with a pet to still be able to continue that. Again, this is Miles, the puppy Miles, who was brought in to work. Again, he belonged to a nurse. I was working at a place in Georgia, and the nurse's dog had had a litter, and so she began to bring in a couple of the puppies to work with her, and she would bring it in during the day, and they would go home at night with her. But it was obvious how much it meant to the residents. They just adored this one puppy in particular, Miles. But Miles was a puppy. He had sharp fingernails. He caused a couple skin tears in residents who were playing with him. He had sharp teeth. And so there was a lot of talk about, well, we can't allow Miles because people might get injured or hurt. And but one of the nurses, who was a very strong advocate for the residents, said, wait a minute, do you see the joy that he is bringing here to the residents? Let's see if we can rethink this. So they had a meeting. They, as staff, said that they would be willing to try and be much more attentive when a resident was interacting with Miles. They did some good grooming, made sure his little paws didn't have too sharp a claws on them. And they tried to, sit with the residents when they were interacting with Miles. And so it got so Miles lived there. He didn't go home at night. He became the resident dog. And it was so meaningful. Different residents would vie for his attention. He spent many a day taking naps on resident beds or on the couch next to people. And it added so much to so much meaning and normalcy to the environment. This is one of my favorite residents, Roy. And he caused a lot of disruption in the nursing home when he moved in. He had been a bachelor. He had been a long haul truck driver, and always kind of lived by himself and been pretty independent. I think you can see from his choice of dress and stuff, he has his own strong personality. And he moved into this nursing home, and within a few weeks, they were talking about, we are going to need to ask Roy to move out. He was attention seeking. If the nurses or staff were trying to help or pay attention to other residents, he would come over. He wanted to be in the middle of every conversation. He wanted the attention on him. He was, of course, wanting to walk out the front door. He had lived independently in his own house a few miles away. He didn't want to stay there. And staff said, we just don't know if we can handle Roy. So when I came in there, Roy was pretty angry. He was causing a lot of disruptions. He was taking staff time away from other residents. The room with the TV, Roy spread himself out on the couch and demanded that this channel be his channel. Other residents so they just avoided him. And it was really changing the atmosphere in the nursing home. So I came in and we began to have some meetings about Roy and what had Roy given up when he had to move in. He had to give up a lot. He had been a very independent bachelor, had a lifestyle that probably the nutrition wasn't very good. If he wanted to eat pizza every night, that's probably what he did. He did smoke. He wanted to continue smoking. He wanted to be able to have his dog with him. So he had to give up a lot when he moved into this nursing home and when they put him in the locked unit. So we began to have conversations about that. And I encourage the staff, the way I phrase it is just pause and be with the resident. Without any agenda, could we devote some specific time to Roy without us wanting him, asking him to do something? Just spend time with Roy and listen to what Roy's real needs were. So we began to work as a team with Roy, and I want to go on to this slide here, and this is in my book. It's one of the tools that I have in there that can help residential care teams assess residents' actions. And again, I don't call them behaviors. I call them communications or actions. So what was Roy doing? He was taking time away from other residents. He was using uncomfortable language that we didn't like to listen to if he didn't get his way. But then we began to talk about his relevant history, and he had been this independent male his whole life. Who was his action causing distress to? Not really to himself, but it was causing distress to others. So we really had to work to see how we could adapt the environment for him. Were we sure he wasn't in pain? He did have a history of arthritis. We knew that he had had some joint pains in his knees and his hips. So we recommended some regular Tylenol for his pain. What techniques could we try? What had we tried to distract Roy? And had there been success? And what were new actions that we could take? And we came up with some plans that we would reward Roy if there were certain TV programs that he wanted. We were going to see if we could set up a separate TV so he could have access to his programs that he liked, but that we wanted to encourage the other TV to still be available for residents. We thought that he really needed to get outside more. We had a volunteer that was willing to take Roy for walks. We also knew that Roy liked to be in control of the situation. So we bought a barbecue for the patio, and he became the barbecue master. Every Sunday would barbecue up for the whole staff and other residents a wonderful Sunday barbecue dinner. And he felt very successful and very recognized for this. So we wanted to give him some successes. So we began to approach it that way. So again, a good way in my mind to approach a resident that we think of as a challenge. I don't, again, label their actions as behaviors, but Christine Bryden, who is living with dementia, she lives in Australia and has some wonderful YouTube videos. She's definitely worth looking up. But she says, my actions may be jumbled or hurtful, but it is my way of trying to communicate. It is communication. It's not bad behavior. And then I want to talk about, as a care team, what do we measure besides measuring things like, have there been any falls today? Or is anyone losing weight? Or have there been any hospitalizations? Again, those are important clinical measures to follow. But I also say, do we measure things that are meaningful to residents? And I think most of us would agree that the ability to get outside is important. When I work with teams, I ask them about, do their residents get outside? And almost always they'll say, oh yeah, our residents, we have patios or we have walking paths. Oh yeah, most of our residents, they can go outside anytime they want to. Well, is that really true? Or is there a big heavy door, or even a door that might be locked? So somebody has to give them permission and unlock the door before they can go outside. Or is the door so heavy that they can't really push it open and access it themselves? So I asked them, well, let's measure how many residents are outside on a regular basis. And almost always they're surprised. It might be a few that it is true, they are outside almost every day, but often the majority of residents are only outside if someone invites them out or accompanies them out, or there's a special celebration or activity out on the patio. So are we making it as accessible? And even just being able to walk from the lobby or the central room in a assisted living to outside, it's a change of environment, it's fresh air, it can add a lot. Do we have intergenerational programs? Sometimes I'll say, oh yeah, we have the kindergartners come in on Halloween and show us their costumes, and everyone loves it. But more than special scripted events, is there a daycare center that you could partner with that comes in on a regular basis? Could you have some children that come in after school and maybe do their homework there? Could the junior high drama club come in and practice their rehearsals there? Could the Girl Scouts have a meeting there? Can there be regular interactions? Because again, that helps break down the stigma and develop relationships. If you can have this flow back and forth of intergenerational interactions. Medications. Do we measure how many medications people are on? Now, in nursing homes, that is required that they track that. In most assisted livings, they can't give me an answer when I ask them, well, what's the average number of medications your residents are taking? Or how many residents are taking more than 15 medications a day? How many residents are taking more than 20 medications a day? So these are things that definitely can impact the quality of someone's day, especially an older adult's day, if they have to take all of these medications. Lots of studies show that if you take over 5 medications a day, you almost always are experiencing some type of adverse interaction from too many medications. So what can we do to look at that? And then mobility. When I walk in to an assisted living or a nursing home, as I observe the environment, I look around, how many people appear to be immobile? How many people are sitting in the same chairs when I come back through in 2 hours? How many people are being assisted to be mobile and change seats and to walk? So important to the quality of their day. I call inactivity and immobility the scourge of old age. It's the tipping point that really quickly adds to debility when someone becomes immobile. And I see staff often encouraging people because they don't want them to fall. They are worried about their safety, but they say, oh, just sit there, Mary, just sit there. I'll be back, just sit there. Well, you know what? Mary wants to get up right now. What can we do to help her with that and give her that choice? Because that is a normal adult choice to be able to get up out of your chair and move when you want to. Polypharmacy, I already mentioned, it can be really add to debility when people are taking too many medications. Our livers, our kidneys just don't process medications the same way that a 20 or 30 or 40-year-old will. And it's a big load on our body when we take too many medications, not all of which are beneficial to us. And then my most important thing is excessive use of psychoactive medications. Again, if we're seeing people's actions as behaviors, it's so common to say she's too anxious, she needs to calm down, let's get her something to calm her down. And then that pill gets prescribed, and you know what? Very seldom does it get taken off. It's on there for months or sometimes years. And that person changes. They don't need that same medication. So if they do use them, it should be for short term. Not very many people truly need these medications if we can give them meaningful experiences. Kate Swaffer, again, Australia is a real international leader on advocacy for people living with dementia. She is living with dementia, has some great videos, short videos you can watch on YouTube. And she talks about dementia. It's a group of diseases or conditions, and the symptoms can be seen as cognitive disabilities. In the same way, if you had a disability that you couldn't use your legs and you needed rehabilitation, or you needed things like a ramp to get up to the doorway to enable you to be independent and have access. So people with cognitive disabilities have the right to proactive disability support, including physical and cognitive rehabilitation. This is an area that we often see neglected. Um, People with dementia often don't receive physical therapy. They often don't receive cognitive rehabilitation. There are some memory care locations that do have some good programs to help keep people's brains active, and but many places do not have any real organized approach to cognitive rehabilitation. So just to touch again on excessive use of medications, people living with dementia have a higher rate of polypharmacy. Polypharmacy is generally considered 5 medications or more than other older adults. So if you compare an 85-year-old person without dementia and an 85-year-old person living with dementia, often the one with dementia will have more medications. And it's, again, who's advocating for them, who's looking at the big picture, who's saying, wow, they really don't need that blood pressure medicine anymore. Wow, they don't need these medicines that they were given 20 years ago. We can start thinking about taking some of these medicines away. So again, polypharmacy, the excessive numbers of medications. And then if you live in residential care, those people have an even higher average rate of polypharmacy. So really something for nursing homes and assisted livings to look at. It's a benefit to the nurses. They don't have to track and pass the medications. The resident doesn't have to swallow them or pay for medications that aren't beneficial. I'm not advocating taking everything away, but just looking at the list and on a very regular basis. Last poll question.
Okay, we are at poll question number 3. People living with dementia have a higher rate of polypharmacy. True or false? Again, people living with dementia have a higher rate of polypharmacy. Please quickly select your answer, and if you're not able to or you don't see the poll on your screen, type it into the chat box. We'll give it a couple more seconds and then close it out. Again, person living with dementia have a higher rate of polypharmacy, true or false? Looks like we got most of the people answering, so I'll go ahead and end the poll. Great job, everybody. I'll hand it back over to you, Anne.
Thank you. After the poll, it takes a minute for it to respond again. Okay. And this is my last slide. So I hope there'll be some questions. We have time for discussion after this, but these are the questions I hope that if you're a professional and work in memory care, if you work in an area that has a locked area, think about, why do we confine residents? Again, who in our society, who in our culture do we lock up and confine? Are we protecting ourselves from the residents? Are we protecting the residents? And this is a long discussion, because many of us have been taught to believe that for the safety of the residents, we need to confine them and lock them up. And I'm challenging you to ask that question. Um, are there maybe when you think of the residents that live in your community, do you think, well, Mr. Jones, he might really wander out the front door, so we better lock him up. Well, we better lock them all up. So are we restricting all of the residents living with dementia because of the potential actions of a few? Is that really the best approach? If you don't have pets in your community, I ask you to ask why not. It's just part of normal life. It brings so much love and real experiences. So I ask you to ask that question. If you do not have pets that live on site, you might have pet therapy, but do you actually have pets that live there 24/7? Surplus safety, I love that phrase. Do we put that in front of resident needs and desires? Often, as a nurse, I'm so scared. I don't want anyone to fall. And a resident wants to walk out on that patio, and I'm afraid she's going to fall off the edge of the walking path and maybe just get off balance and fall. So does that mean that she can't go out, or she can't go out until I have a few minutes to go with her? Is there anything that we could do? Could we do zone staffing so we have someone positioned out there, so a staff member that can help and assist people, but that the doors are open and residents have access? If a resident does have some challenging actions, can we think of those? What are they trying to communicate? Is this really just maybe a normal adult reaction to what's going on in their environment, or to perhaps confusion in their head? They're having trouble putting things together. Where are they? What's going on? And so is this a normal adult reaction? And could we approach it that way, instead of thinking of it as a behavior that needs to be managed? Do you think that in your community, excessive medications are ever used, really for the convenience of the staff? I challenge you to think of that. And then the last thing is there one resident that you could advocate for? Can you think of the residents that live in your community? And is there one resident that you could say, I think there's a new thing, a new choice that I could offer him that would be meaningful. I'm going to try this. I'm going to just pause and be with that challenging resident instead of avoiding them or talking about their bad behaviors. I'm going to advocate and see what I can do that would be meaningful for them. So again, that's my last slide. I want to thank you all and for your attention. And if there's any questions, Lauren, let me know.
Okay, perfect. Thank you so much. What a valuable topic and such useful information. We want to remind everyone of the importance of being aware of implicit biases or unconscious stereotypes as we care for others. A best practice is a person-centered approach where we view each person that we care for as an individual with unique needs and the preferences, and treat them with dignity and respect, even when they are very different from ourselves. If we always listen carefully and respectfully so that we understand their perspectives, values, and preferences, we can build trust and provide the highest quality of care. And I think that was perfectly reflected in today's presentation. So now if you have any questions for Anne, please be sure to type them into the chat box. We do have a few questions already, so please stay with us. But before we begin the Q&A, if we do run past 12:30, you are welcome to remain online to ask your question or listen to the answers. But if you need to leave the webinar, you can. Just remember that if you want to earn CE credit, you need to be online for the full 60 minutes. Also, I wanted to take this time to thank our sponsors one more time for making this presentation possible. We're so grateful for the support from O'Connor Mortuary, Care Choice Hospice and Palliative Services, and Caring Companions at Home. And don't forget about our next webinar on July 24th, which we will be offering continuing education credit. It will be on the topic of the best friends approach to dementia care with David Troxel. Okay, so now let's get to our questions for Anne. So Our first one is, would you please share a peer review regarding evidence-based strategies for creating a culture consisting of empathy, dignity, and respect?
Well, let's take a couple hours to answer that. So I'm sorry, how was that phrased? A peer review?
Is there any peer reviews regarding evidence-based strategies for creating a culture consisting of empathy, dignity, and respect?
Um, well, I think there are some out there, and I hesitate to recommend one specific one. But I think if you follow some of the questions here of what are you measuring where you work, and are you measuring only clinical outcomes, or are you measuring a resident's inabilities instead of measuring things that are meaningful? You'll begin to see the culture change. And the way I like to look at that is, as a nurse, I often hear all about a resident's inabilities when, especially when a new resident moves in, I'll get all this information. Or if you work in a nursing home and you're looking at the MDS scale, it's all about a person's inabilities. It's not about their strengths. So challenging yourself to have a strength-based approach really will move towards changing that culture where you work. If someone wants to contact me afterwards, I can give them more information on various screening tools and culture changing approaches, but there's a few good ones, and I hesitate to mention one right now.
Okay, perfect. Thank you. How can I, as a caregiver, make a change when the culture is driven by the executive director?
Yeah, such a great question. Good for you for asking the question. And you're right. There are many things in your day as a caregiver that you don't have control over. But I think if you perhaps maybe just bring it back to one resident, start with one resident. What can you do that would make a difference to that resident? And it can be something as small that you might have control over, a resident who sits for prolonged periods in a chair. Again, we're looking at increasing debility. We're looking at her or him not having the choices of being able to relocate to another room, to another chair, even perhaps being uncomfortable. Could you just, on at least an hourly basis, would you have time to approach that resident, spend a couple minutes with them and say, I'm going to help you move over here? Or would you like to come with me out to the patio? So helping someone who is immobile, perhaps to have a little bit more mobility and choice in their day. Perhaps you can start doing things like that. Perhaps looking at their actions as communication, and not, this is a behavior that I want the nurse to get a medication for to calm this person down. Think of it in a broader sense of what's going on for this person. Could they be in pain? Could they be bored? I often think that in some of the locations, they're just sitting there. Could they be bored? I mean, so again, thinking, like Lauren said, in a very person-centered way, what might be meaningful for this resident and what can I bring them? But I agree with you, many things you don't have control over, but I really appreciate the caregivers who make it as an individual, in, they advocate for that one specific resident that they are working with that day.
Well said. And I think the change starts with just one person, and everybody can see that success. They'll start adopting those behaviors as well.
Yes.
Someone asked if you can put the reference slide back up.
Sure.
Perfect.
Mhm.
Thank you. Okay. Are there any specific programs that you recommend where someone can learn how to support people with dementia, i.e., engagement programs?
Yeah. Um, Again, there are some, and I think if you attend the next CEU performance that Lauren referenced coming up in a couple of weeks, the best friends approach, I think, is one that's helpful in that. But again, I refer. I've already mentioned a couple of things on YouTube that you can see. Um, uh, YouTube is a great source. There's a lot of things that aren't accurate and maybe not so good, but I think you can begin to learn uh, watching and listening to people who are living with dementia instead of us as either the family member or the professional thinking we know it all. Start by going into listening to Christine Bryden. Start by looking at Kate Swaffer, who is here. Just put their names into YouTube, and there's a lot of good information there um, about what people want. And and I think we often think we have to do some kind of organized, almost sophisticated type engagement for someone. And often it's nothing more than saying, come with me, I need your help um, trimming the flowers outside. Come with me. Um, I'm going to put the dishes out on the table for dinner. Can you help me with that? So it doesn't necessarily have to be anything sophisticated uh, if you know the person well.
Can you, that name that you just mentioned, Kristen, can you repeat it, please?
Yeah, it's the second one here on the reference slide, Christine Bryden.
Okay,
Uh,
perfect.
mhm.
Oh, I mentioned, I'm putting that in the chat for everybody. Okay. Um, what are good activities that we can give to people with dementia, as it's hard to introduce new faces to them sometimes? That's a very specific question. Um,
Yeah,
I think just let's do just the broad of the good act. What are some good activities?
yeah.
Um,
Well, um, again, I think it's going to be. I would not come out with something broad because it's going to be personal. I know that assisted living and nursing homes, they have very creative people and they put a lot of expertise and sometimes even expense into developing pretty sophisticated engagements or performances for people to come and observe, but it's not going to be for everybody. So uh, I couldn't say that people with this would be a good engagement for people with dementia. I love things that keep people active, physically active. So, but again, it's going to be individual depending on their interests and abilities. And what's going to get one person up out of their chair and willing to take a walk might not work for the next person. If we had more time, I could tell you great stories about, you know, Ted who lived in a community in Tustin. Real quick, because it's such a great story. He was able to get out of his assisted living community. He was pretty high functioning, a good dresser, and he often would just walk out the front door with visitors or something, and then we would go, "Oh no, where's Ted?" You know, and Ted had gone, you know, half a mile down the street to where his house was. He still knew he knew this town very well, and he could get there. So we said, how can we? Ted wants to walk. He wants to leave, have access to leaving. How can we give him that success and also keep him safe and let him do this? So we found out Ted had a dog that his son had taken over. We talked to his son. We said, could the dog come and live with us where Ted is? So Ted got his dog back. So now if he was going to go for a walk, we could kind of see that he wanted to get outside because he began to call his dog and he began to get the dog leash. And so that was our cue that, oh, Ted's getting ready to go outside. Okay, so that gave us a little warning. We also made Ted head of the men's walking group, and he liked that. So he would start talking to his buddies in the community and going, "Hey, Bob, let's go down the street. Let's go for a walk." And so he would start to gather his friends who lived in the community with him. So we knew that he were going out. And then we could say to Ted, "Okay, Ted, that's great that you and your friends want to go for a walk. Our caregiver, Joanne, is going to go with you. Not for you, you don't need any help, but just in case any of the other guys might need some assistance." So Ted could accept that. And so we had these little groups and they would walk around the block. And it was just really charming. And he did this 2 or 3 times a day, taking his dog and his friends for a walk. So it was great. It was a great win-win for everybody. And we didn't want to take that away from him. That's a great ability. We wanted him to be able to do that.
Perfect. Do you mind going to the last slide for me?
This one?
One more. One more.
Okay, Lauren.
Oh, no, the very last one. Very last one, whatever that one might be. It has the landing page.
I'm
There,
sorry.
perfect.
Yes,
There it is. Okay.
Okay.
So a couple questions a few people have been asking for a list of resources for various topics, which we won't really get into right now because some of them are pretty broad. However, Anne has put her email address available to everybody, and you can also call our helpline at Alzheimer's Orange County. We can provide those resources for you. Also, to talk about learning more about those with dementia and how to better support, I did put it in the chat. We have here at Alzheimer's Orange County, we have a program called Dementia Friends, which is a relatively quick training, more about dementia and how to support those in the community. So that information is there if anybody's interested.
Great. That's great.
So as we go back, someone asked, is there any place in the US that uses the concept of a dementia village as they have in the Netherlands?
Mm. Not that I'm aware of. That's a real interesting concept. They basically build like a little village, and people can wander around from one location to the other, go to the store, go to the library, go to the pub and have a beer if they want. And it's all within a small village that's been created. And as far as I know, that has not been recreated here. We have a very different model here, and unfortunately care is almost always private based in the United States, and the expense for that in Netherlands, that is paid for by the government.
Okay, very true. What do you recommend for those living at home? How can a caregiver be able to find strategies to communicate when a family member with dementia can't communicate through words anymore?
Yeah, so tough, so challenging. Most studies show that really 70% of people who are affected by dementia are living at home. And so the family is providing that environment for them. And I'm sure Lauren can talk better than I can about the need for family members for themselves to have support. And it can be a big task and complex. And so I very much, as I was saying earlier in the presentation, pause and be with, just listen to them. What are they communicating? They might not be able to articulate it. They might be frustrated, and so it's coming out in outbursts. Sometimes, unfortunately, even some what seems like aggression. But if you think about how any of us might feel in the same circumstance, to be so frustrated, not able to express yourself, perhaps seeing the other person as restricting and confining you and not maybe understanding why. So it can be such a difficult situation. In my book, I do have sections for people who are living at home. And I talk about the hybrid model almost, where perhaps at a certain point, the person living with dementia might spend a few hours a day or a week at another location, but they're still coming home and living at home. But maybe there's an assisted living or nursing home that will have people come in for a few hours, maybe for lunch, maybe for some of the activities or engagement, gives you time. And they also then get introduced to other environments and other people. So sometimes what I call the hybrid model can work well, but every situation is so unique, so unique.
And to add on to that, I hope you don't mind, but also communicating um, through touch, through contact, as Anne said, just sitting there, being with them, holding hands, hand massages, just being present
Yes,
um, is
so
very
important.
important. Um, in quality of care of your expertise and experiences, what areas of gap need to be filled for the person living with dementia for there to be more meaningful without feelings of confinement or isolation from family and community?
Yeah. Well, I think, dismayed how many new memory care communities continue to be built and have a locked unit. I hate even using the term unit, but instead of, because studies show that the majority of people living in assisted living or nursing homes have some cognitive changes. So to say, well, we have a memory care unit in the back here that's confined or locked, and that's where we put the people who are living with dementia, that's not completely true, because if you do assessments of people who live throughout the house, the majority of people, not all, but the majority of people will have some cognitive changes. So how do you decide who's going to be the people who live in the back? And why do we need to confine them? I think we just have to ask ourselves that. I think people living with dementia and their family members need to start asking that when they look at a residential care site. Is this really where I want my husband or my father or myself to live in an area that has a locked door? They're going to be very frustrated. What is it going to? So that's the first thing, is start asking those questions of the staff at these places. Why do you confine people? And they're going to say, oh, it's for their safety. We don't want them to wander out to the street. That's a good consideration. I of course we would not want that to happen, but I'm saying that there are communities who are not designed that way, and they do not have a higher rate of any problem like that. They just they change how they perceive their residents living with dementia. They change their staffing model and setup, and you do not have to confine people in a locked area.
Okay, perfect. In the public schools, we often use functional behavioral assessments to determine triggers, which then allows the staff to formulate a plan to promote positive behaviors and interactions. Is this something that is ever done in residential facilities?
Similar, and I had one slide that I was talking about that resident Roy with the tie-dye shirt on. There is a tool in my book that is really in many ways a functional assessment, and staff can use it to look at the actions of residents. And again, while we want Roy to change his actions, the staff also had to be willing to change their actions and their approach to Roy. So it's a two-sided thing. And so there is a tool in there that I use at many of the places where I do training.
Okay, perfect. And then last question. Any recommendations or tips for an administrator that has a small residential assisted living facility?
I love that. And I appreciate it when leaders are willing to ask questions. Um, so you say a small residential. I don't know if that might be a place that only has 6 residents or if it's a larger one, but I think it's in some ways the same, depending on the size is not so important. Um, and again, I apologize. I don't mean to continue to refer back to my book, but there is a tool in there for assessing your residential care environment. And then I would do that assessment as a team, not just you as a leader, but every caregiver, the person in the kitchen, the person doing the laundry, everyone's involved in doing the assessment together and meeting together and then setting up some priorities of, and you don't want to bite off more than you can chew. You're not going to say we're going to change everything immediately, but setting up some priorities, and it's a team approach. For instance, I when I'm asked to come in and consult and do trainings, and they say, okay, here's 30 of our caregivers for you to train, I go, I won't actually even do it unless the leadership is there too. Because as one of the caregivers who had a question says, often they can't control a lot of things. It's a team approach. The leadership understands what the priorities are together, those are established, and they support each other. The leadership supports the caregivers and vice versa. They all are together clear on what the approach is. So I would do an assessment of your residential community, no matter what the size, with everyone on the team. Meet together. You learn a lot when you have everyone in the room at the same time, and see what you think your priorities are and what you can begin to change.
Okay, we actually had one last question. It's a good question. Most of the facilities have a locked area, and if a resident was able to access the outdoors, parking lot, street, etc., they may get injured. So, do you recommend all facilities rebuild their facilities?
Um, well, in a real simple response, yes. Um, do I recommend that residents be allowed to walk out into the parking lot or the street and get injured? Of course not. That's horrific. We don't even like to think of it, and we would not want it to happen. But is the solution to confine them behind locked doors? What does that say about their dignity as an adult, as a person, as an individual? So there are places that are successful that do not have a confined unit. Some of them, some large memory care places will have the front door has a keypad, is coded locked, but the whole interior, there are no separation, no units, nothing off limits. The doors are open to the patios, so the person is often can walk completely around, go outside, come in, and if they are insisting on walking out the front door, there will be perhaps a barrier there, but staff are encouraged then to take that person out. If they are insisting on that they need to get out that front door, what can we do to do that, just to show them that, yes, we're going to allow them to do that. So if it's that important, how can we allocate staff to make that happen, at least, on somewhat of a regular basis, but no confining to a small unit in the back.
Okay, perfect. To be fair, Deborah did say your philosophy is wonderful, so it was just
Yeah.
challenging the status quo.
I'll just say in other countries, they don't build memory care units like we do. Someone already mentioned the Netherlands, and that's, perhaps unrealistic, but they do not build nursing homes and elder care and residential communities where they have people with dementia locked in a unit. They are integrated into the whole space, and that's a much better solution. So I know it's possible. I've seen it.
Mhm. Okay, that looks like that was the last of our questions. So that brings us to the conclusion of our webinar. Thank you so much again to our presenter, Ann Ellett. Thank you for sharing your time and expertise with us. And please watch for the survey that will open up immediately as you exit the webinar. And watch for our flyer for the next webinar on July 24th. And feel free to forward it on to anyone who might be interested. And don't forget, you can visit our website, www.alzoc.org, to learn more about our education programs and webinars, and to view recordings of the past webinars for free, although no CE credit can be earned by viewing these recordings. So thank you all again for joining us today, and have a great rest of your day.